Protocol 46 is our respiratory distress pediatric protocol. And again, it's broken down between a wheezing and a stridor patient. Wheezing is broken down further as to whether or not the patient is under 1 year of age, or whether or not this is their first wheezing episode or this has happened before. Okay, so for our wheezing patient, over 1 year old, all provider levels will be administering albuterol, nebulized at 2.5 milligrams and 3 mLs, normal saline times 3 as needed. If there is no improvement, the EMT will administer the EpiPen greater than 30 kilograms and the EpiPen Junior if the patient is less than 30 kilograms in weight. Now, if that patient is under 1 year old, and this is the first wheezing episode, all provider levels will administer albuterol nebulized 2.5 milligrams in 3 mLs of normal saline times 1 as needed. If this is not the first wheezing episode, albuterol nebulized at 2.5 milligrams in 3 mLs normal saline times 3 as needed. Okay, continuing with the wheezing patient that is over 1 year old, the I&P level treatment. They will also administer the methylprednisolone or Solumedrol at 2 milligrams per kilogram IV, max dose of 125 milligrams. And if no improvement, they're going to administer epinephrine 1 to 1,000 at 0.01 milligrams per kilogram IM to a max of 0.3 milligrams. Now, if that patient is under 1 year old and this is their first wheezing episode, of course, the albuterol 2.5 and 3 mLs normal saline times 1 will be administered by all provider levels. And if no improvement, the I&P level can administer epinephrine at 1 to 1,000 nebulized, 2 milligrams of 1 to 1,000 in 3 mLs of normal saline. Okay, so we just went over the patient who is under 1 year old, and this was their first wheezing episode. Now we're going to talk about the patient who is under 1 year old, and this is not their first wheezing episode, or they have a history of asthma. For all provider levels, they're going to administer the albuterol, 2.5 milligrams in 3 mLs of normal saline times 3, if no improvement. For the I&P level provider, you will administer the methylprednisolone or Solumedrol at 2 milligrams per kilogram IV to a max of 125 milligrams. Okay, so in Protocol 46, now we're going to look at the patients that present with stridor. And for all provider levels, for the EMT, you're going to administer the EpiPen. Patients greater than 30 kilograms, the EpiPen IM, and for patients less than 30 kilograms, the EpiPen Junior IM. For the I&P level providers, you're going to administer epinephrine 1 to 1,000 nebulized, 2 milligrams in 3 mLs of normal saline. And if no improvement, you're going to administer epinephrine 1 to 1,000, 0.01 milligrams per kilogram IM to a max dose of 0.3 milligrams. Also, the administration of methylprednisolone or Solumedrol at 2 milligrams per kilogram IV to a max dose of 125 milligrams. Okay, Protocol 47 is our seizure protocol. Okay, so the first question we want to ask in the seizure protocol is the patient actively seizing? If the answer is yes, our I&P level providers are going to be giving the same anticonvulsant that they are in their current protocols, and that is midazolam or Versed at 5 milligrams IV, IO, IM, or IN every 3 to 5 minutes as needed to a max dose of 10 milligrams. Now, we do want to assess, and if we have active seizing in known or suspected pregnancy greater than 20 weeks gestation, we will administer magnesium sulfate at 4 to 6 grams IV IO over 5 minutes for eclampsia. Protocol 48, our stroke and TIA protocol. No real change from your current protocol. You will be assessing the patient using the Cincinnati Pre-Hospital Stroke Scale. Protocol 49, our tachycardia adult protocol. First thing we need to ask is our patient stable or unstable? So let's take a look at this. Tachycardia adult for the I&P level provider. If the patient is unstable, has serious signs and symptoms, and the heart rate is typically greater than 150 beats per minute, we will be administering Versed to sedate the patient, 2 milligrams IV, IO, IN, and you can repeat to a max dose of 10 milligrams. And we will synchronize cardiovert our patient. Also need to consider adenosine, 6 milligrams IV, IO, if regular and monomorphic. And you can repeat that at 12 milligrams if needed. Now, if that patient is stable, but the QRS is wide, which is a QRS greater than 0.12 seconds. If it's regular and monomorphic, we will administer the adenosine, 6 milligrams IV-IO, and you can repeat at 12 milligrams if needed. Also, consider amiodarone, 150 milligrams IV-IO over 10 minutes, and you can repeat that one time if needed. If the rhythm does convert from amiodarone, we need to hang that maintenance infusion of 1 milligram a minute IV-IO. And of course, we need to consider mag sulfate for torsades de poids, and the dose is 2 grams IV-IO over 5 minutes. Now for our stable patients in tachycardia with narrow QRSs less than 0.12 seconds, we want to first attempt vagal maneuvers and then move on to adenosine, 6 milligrams IV-IO, if the rhythm is regular and monomorphic. You can repeat that at 12 milligrams if needed. Irregular rhythms, or adenosine does not convert the rhythm, you will be administering metoprolol at 5 milligrams slow IV push, and you can repeat that every 5 minutes to a max dose of 15 milligrams. And of course, 12-lead ECG procedures after rhythm conversion. Okay, and below is a chart for synchronized cardioversion. This can be found in the procedures section of the protocols, procedure 14. Atrial fibrillation, we want to start at 200 joules. Atrial flutter, 100 joules. Ventricular tachycardia with pulse, 100 joules. And supraventricular tachycardia, 100 joules.